Can I start now, Nazreen? Okay. Good evening, everyone. My name is Vimal. I would like to invite you to our second webinar series. This time we are going into bariatric and metabolic surgery. I think our sponsor's video was very timely and a good intro to the session. So I welcome the faculty. We have a very eminent field of faculties who need not much introduction really, because they have actually shaped the direction bariatric surgery has taken in the world, in Asia in particular, and also in Malaysia. So my co-chairman for this session will be Dr. Gafur Mubarak and Dr. Mark, who is upcoming bariatric surgeon in Ipoh Hospital. So they will help me with this webinar today. I would like to thank the organizing committee consisting of Mr. Kirubakaran, who is also one of our faculties. He went to a great deal to organize this session. Also to our PCO and Azurin in particular. So before we start, I introduce the first speaker. I would like to tell the participants that the Selsma membership is open, and we are giving during this period of webinar, we are open to application for membership. Okay, we are giving a free membership with Malaysian Hernia Society for every application for life membership to Selsma. Okay, so please register now and help us to help you. Okay, for this webinar today, we can get the MMA CPD points, 2 points. Okay, so I hope you will register, watch, and claim your CPD points using your QR code. Okay, the co-chairman, anything to say?
Thank you, Mr. Vimal. I think you've said quite a bit. I think it's well. I also echo the same call that everyone should join Selsma and take this opportunity. And we'll be planning more programs in time to come. Thank you.
Okay. So without further ado, I would like to introduce our first speaker, who none other than Professor Huang from Taiwan. He is actually, to friends, he is known as CK. So he has been a friend to all the bariatric surgeons actually, Asia, from the rest of the world, and Malaysia in particular. He has helped shape the development of bariatric surgery in Taiwan, Asia as I know it. Also, he has trained a lot of surgeons in Malaysia. He is the Superintendent of Body Science and Metabolic Disorders International Medical Center of China Medical University, Taiwan. He's also on the board of directors, Taiwan Obesity Support Association, and he is a founding chairman of a very famous organization, the International Excellence Federation for Bariatric and Metabolic Surgery, where a group of self-enthusiasts in bariatric surgery, they gather and discuss and get better year on year. Okay, his honors are multitude. He has achieved many firsts during his journey into bariatric surgery. He's on the editorial board of many international journals. He has published books. Okay, his published papers up to June 2019, I think it's 77 and counting. Okay, so you need one webinar to go through his CV. So I would like to invite Prof. Huang to deliver his lecture on bariatric and metabolic surgery in the COVID-19 pandemic era, the view from Taiwan. Welcome, Prof. Huang.
Hi, good evening.
Hello, hi.
Hello, hi, everyone can hear me?
Yes, we can see you also.
Okay, so first I want to thank the organizer of Selsma, and it's my honor to talk in the webinar with you in the sky. It's very unhappy that we cannot meet in this year. I think because of the COVID-19 pandemic problems. But fortunately, as I know, all the surgeons in bariatric and metabolic surgery field are very safe. So it's our happiness to see that it's a good news. Today I was going to talk about bariatric and metabolic treatment during COVID-19 pandemic. The view from Taiwan. I'm from China Medical University Hospital, Taichung, Taiwan. Okay, so I have 15 minutes to talk to you. So I will do it as soon as possible. I'm going to talk about Taiwan condition in COVID-19 and how the Taiwan government policies and how's the treatment in elective procedures in our centers, how's the results and further discussion and my recommendation and conclusion. I think most Malaysian people know Taiwan very well. We have the official name is Republic of China, but it's quite different with the People's Republic of China. In fact, we are two different political area. Maybe not suitable to say country, but right now Taiwan is quite independent. But the problem is we are very close to China. The closest the area is only 140 kilometers away. So to take the flights, in fact, 1.5 hours can reach. And in fact, during the pandemic problems, we was believed to be the most dangerous place in the pandemic infection in the beginning. Till now, till yesterday, the counting numbers from Taiwan is, in fact, total is 591. Okay, so only less 600 cases was get infected, but reported is quite a lot, almost 1 million, but in fact, 97% was excluded. Till now, we have 7 days, okay? And totally confirmed cases is 524, recovery is 487. We do a lot of tests too. And in fact, the test was covered by the government mostly. So in the figures, you can see we have one most outbreak during the April, before April. After that, it's very silent in the infection conditions. So how Taiwan control the COVID-19 effectively? I think there's a few reasons. One is the government react very quick. We have very early lockdown from China for the policy. We have strict allocation of surgical masks to all the peoples. And the people have very strong discipline. Number 5 is medical system is very well prepared for these conditions. The first, the virus start from Wuhan of China. I think most of you know that. And in fact, we have a lot of travel from China to Taiwan for trip or for business. So when it's starting, the Wuhan virus was discovered, then we start to assess the passengers before their departure to Taiwan. Those who have fever, respiratory symptoms, those who have travel histories, they are not allowed to come to Taiwan anymore. Okay, so for our CDC, Taiwan CDC, then we start to have the action in the beginning. Since the 20th January, even in Taiwan, only 1 case confirmed, but we have the President Tsai has assigned commander, the director of the chain or Ministry of the Health and Welfare to start to control the condition. And he holds the press conference every day since that times. Then share all the information to the public and all integrate the government department in one direction to try to make all the public understand the policy and follow the guidelines. So we start to lock down the people from China and even the foreigners. So there are 2 actions. In January 26, there's no any Hubei province China people was allowed to enter Taiwan. And till the February 5, there's not any Chinese allowed to come to Taiwan. But until the March 19, there's not any foreigners allowed to come to Taiwan. So Taiwan locked down for the whole island after the outbreak starting after 2 months later. Okay. Then we also do allocation of surgical masks. So all the surgical masks were implemented by the government from the 6th February, then to restricted by the government that no one can buy more than 2 masks per week. And it's a very regulated prices covered by the government. The money is very small, so everyone afford to buy the mask. So everybody go out wearing the mask. Government increased the mask production even up to the 17 million a day. The mask was always available for all the healthcare professionals under government control. Then the people's discipline, I think till now you go to the street, go on the street in Taiwan, still almost all the people wear the mask spontaneously. And we have very strict home isolation and quarantine policies. The figures that you see, that this is my kids, okay? Because my wife that times goes to America to visit his family. Then when she come back, she have to do home quarantine for 14 days. So even my kids cannot meet with her. So she take the photos from inside the room. The kids is very stressful and even to cry, but 14 days you cannot meet is a strong guidelines for them, okay? So, and medical system was also very well prepared. In fact, we have ever experienced SARS 17 years. I think South Asian country, very few country ever see that. So that time in Taiwan, there's 73 deaths. And even there's medical doctors and nurses die from the SARS. So now Taiwan on 1,100 negative pressure isolation wards. According to the population, 23 million. In fact, Taiwan is the highest density of the isolation ward for negative pressures. So all hospitals and clinics are integrated by the government these times in standard pathway for detecting and managing COVID-19. So till today, Taiwan still perform elective surgeries and run clinic every day. We don't have any setting limitation for that. Then for healthcare, the travel restriction from the government, in fact, they since the February 24, there is not any doctor nurses can fly abroad because they are afraid of when the outbreak happen, then there would be shortage of the medical professionals. But in fact, we cancel it after July 1st because the numbers of the cases very, very low in Taiwan now. Otherwise, I think Taiwan government and all the medical and surgical society, till now, we did not set any limitation for running clinic, endoscopic procedures, and elective and open or laparoscopic surgery till now. Okay, so according to the IFSO, published in April 14, they say there's no elective bariatric surgery and treatment was recommended in the world, but in Taiwan it's a little different. So I'm going to tell you the numbers that we have done in these 9 months from the January to September. I compare with last year. So you will see before the patient come to our hospital and the centers, of course, they need some screening, including the temperature checking, including the history taking. And when those who have some problems, we suspect we will refer to emergency department, or if there's no, we still can do operation for them after checking all the basic data. For healthcare workers, in fact, Taiwan CDC and hospital all have guidelines for them. So those who have the risk factors, including some infection from the upper airway infection symptoms, in fact, we will quarantine the healthcare professionals and then also do some tests for them. Okay, so how we do that? In fact, the indication and patient selection done accordingly. Those who need the treatment, we do the same, all the pre-op checkup, and also endoscope, echo, EKG, X-ray are all the same, but we don't routinely do the chest CT scan. unless those who have some suspected findings. Okay, of course the MD teams the same. We run in the same. All are performed by laparoscopically or endoscopically. So this is a number that you will see in last year from January to September. Total, we have 567 cases. This year, in the same period, we have 598 cases. So you see the numbers in different months. In fact, we did not see any difference. There's no any difference over that. So I think especially for no matter bariatric surgery or bariatric endoscopic treatment, in fact, we provide almost the same. And the patient right now, they even don't feel any afraid to come to hospital and center for treatment. And for those who are coming for the surgery or treatment, there's no any reported cases of postoperative patient develop fever or unknown reasons or need any COVID-19 testing. There's only one complication is the staple leak from the Cushing syndrome sleeve. It's 0.16%. Then was successfully managed by reoperation. We don't have any mortality. Then there's no difference on length of hospital stays for both groups. So in fact, in the beginning, we also encountered the patient is so afraid to come during the April when there's some outbreak. So we are trying to do some contact with patient. So we are going online. So we have free online consultation by appointment via the line, WhatsApp, and some social media. So every day we have 5 to 6 free consultation online. So it is quite helpful. So this is my recommendation for all the surgeons in Malaysia. If you, the patient is still afraid to come to your clinic, I think you can start this free online consultation, even can give some prescription from your department. Then, so we start the service since April, but because right now all the patients can come to the hospitals without any fear, so we stop the service at August. Okay. Then this is the condition right now. In June 29, the foreigner now allowed it to visit Taiwan for business after negative test and 14 days quarantines. And since August 1st, the Taiwan government announced that we start to provide international medical tourists for medical service for those who want to come to Taiwan for medical care. So the Taiwan border is open again. Okay, and in the end, I want to say, I think everything routine is the same in Taiwan. And this is the first endoscopic sleeve gastroplasty was performed in Taiwan just only yesterday in our center by Dr. Liu. So the treatment is very successfully. So that is a very good news for our center. And I think for most Asian surgeons who want to start this service in the future, I think if you want to see, you can visit Taiwan too. Okay. So my conclusion, I think, would be elective bariatric and metabolic treatment do not need to be postponed in some area, especially those who don't have community transmission area. There's the proper screening and protection manners. Those who have standard protocol and executive pathways. But I think that if you want to produce the sustainable service, I think you need the flexible marketing strategies. That is what we are providing to our patients. I think Taiwan might be possibly used as a model system for the future pandemic outbreaks. I'm very happy to see that Taiwan has a good results because of very strict government rules, and all the people and healthcare professionals follow the guidelines. So I think right now we still very safe. Okay, so in the end, I want to thanks to the organizer, and it's my very big honor to serve as a speaker for you. Thank you very much.
Thank you, Professor C.K. Huang, for the very enlightening talk on the management of bariatric and metabolic patient in the COVID pandemic era. I would like to ask Dr. Ghaffur to introduce the next speaker.
Thank you, Mr. Vimal. So thank you, Professor Huang, again. Our next speaker is no stranger to all of us in Malaysia. He is Professor Madya, Dato Dr. Nick Ritza Kosai Nick Mahmood. We know him very fondly as Prof. Nick. Prof. Nick's CV is very, very long and very established, and part of it is he has began working in UKM and established the Upper GI and Bariatrics Unit since 2011. He has published over 100 peer-reviewed publications, including book chapters, expert opinion. He sits in various committees, including the subspecialty upper GI training in Malaysia. And also he is the president of the Malaysian Metabolic and Bariatric Surgical Society, or MyMBS. And he's a vice president of the Malaysia Upper GI Society and the president of the Malaysian chapter of IFSO. It gives me great pleasure and great honor to introduce Professor Madya, Dato Dr. Nick Ritza. Prof. Nick, the floor is all yours.
Good afternoon, everyone. Let me just share the screen first. Can you hear me? Can you hear me?
Yes, yes, we can.
Yeah.
Yeah, we can see your slides.
Okay. So basically, first of all, I would like to thank the Selsma committee and the organizer. It's a great pleasure also today to be talking with the presence of Prof. C.K. Huang and the rest of my colleagues. Okay. So the topic of the talk today is bariatric surgery, the new normal for Malaysia. I have nothing to disclose except that the fact is for every one normal BMI patient, there will always be another one person who is either obese or overweight, okay? And this is getting more common now. This is a case where we did, I think a few years back, 327 kilos, had to get the fire brigade to break his door and bring him down. Fortunately, the ambulance is big enough to carry him in hospital. So we had to admit him for at least about 6 weeks to get him prepared well before the operation. Underwent sleeve gastrectomy, obviously, because that's the most appropriate surgery for him. And the last time I saw him about a year and a half ago, a year and a half after the operation, that's what he is now. So this is getting more common, and we are getting a lot of referrals with a BMI of more than 50, and we have at least several patients on the ward with at least 250 kilos above. So it's definitely a norm now in Malaysia. Plus, also, we are getting a lot of patients not only obese, but they've got diabetes. And the profound effect after surgery, where you can see, the impact on patients' diabetes, where the diabetic improvement and resolution happens within 6 to 9 months in this case. So this is the content I'm going to talk about. There are a lot of slides, but I'm just going to whiz through, as seamless and quickly as possible. So basically, I think everyone knows, even Prof. Huang is aware that Malaysia is one of the obese countries in the world, probably one of the unhealthy country. However, surprisingly, COVID is one of the, obesity is one of the risk factors for COVID, and now with the era of COVID, so I think we have to take our health seriously. But the good news is at least the death rate from COVID in Malaysia is still low compared to other nations. It's a global pandemic. I think one of the reasons why there's about over 1 million now people die from COVID, and if you look at the statistics, they all have comorbidities, and one thing in common, the majority are obese. This is the Malaysian situation. We have a population of 33 million, and you look at the statistic, which is not desirable at all. And if you look at every state in this country, nearly 50% of this country's population in each state has an average of at least 50% overweight or obesity. And this is supported by the Lancet study back in 2014 that shows Malaysia is the second fattest country in Asia. And this is the latest NHMS in 2019, Malaysian statistics, which is very worrying. 1 in 2 Malaysians are either obese or overweight, and 1 in 2 of our population has abdominal obesity, which is a source of metabolic syndrome. So complications of obesity, you can see at least it attracts a lot of medical problems, at least 65 major medical problems. And this another Lancet study showed that if you're obese, if you have metabolic syndrome, your lifespan will be shortened. Simple as that. And of course, this is the what's coming up more regularly in this country's media, and it's basically showing that the alarming rate of complications, in particular non-communicable disease. So this is another latest statistics, which is again worrying, that the rate of diabetes has increased from 13% to 18% in just a short period of 4 years. Okay, so this is very, very worrying indeed. And what's more worrying is that these diabetic patients, the compliance rate and is very poor. As a result, diabetic control, the ideal diabetic control in all these patients is very, very small. So it's only 1 in 5 patients is in good diabetic control, despite on numerous medication that they receive. Presumably, at least 60–70% of these patients will be obese. And of course, it's very expensive, very expensive. So if you look even at, this is a breakdown of different complications from diabetic patients. If you look at nephropathy, which requires dialysis, it costs per year, per individual, nearly 42,000 ringgit. It's about 10,000 US dollars. And total cost of diabetic management per year comes into millions. Okay, so imagine if we can try and reduce the risk of obesity and diabetes. So much we can reduce the amount of health GDP in this country. I think everybody knows the cause of obesity. It's just not simple. Otherwise, we would have a magic pill that can actually solve this problem without needing surgery. And obviously, apart from eating too much, we just don't exercise enough. And if you look at the latest statistic in Malaysia, only 1 in 4 adults in Malaysia is just physically not active. But more worrying, if you look at students, young adults and young people in this country, 40% of them just don't exercise enough. So it's worrying. Treatment of obesity, I think we all know that these are the 3 main core. Okay. Drug works, but the problem is side effects and the rebound effect once you stop these medication. And of course, the body physiology is always trying to counteract any losses, especially if you look at the ghrelin level. So every time you lose weight, the baseline of ghrelin will go up. So, you're fighting against a devil in disguise. So, there are so many options of treatment of obesity, but without doubt, bariatric surgery is the most effective way and most durable. I congratulate Prof. C.K. Huang for starting the endosleeve, which is still not available in this country. We have everything else apart from endoscopic sleeve procedure. But intragastric balloon is another treatment option that we have in Malaysia. And we have also the ellipse balloon, which I think Kiru has done a lot, and I've used in several patients as well, and I'm quite impressed actually. 4 months, which is quite reasonable time, and it's very easy to perform, completely swallowable, and no procedure required at all. I think the material is much more comfortable for patient compared to the SPATS balloon. Of course, this is a systematic review which shows that whatever you compare in terms of treatment for obesity, surgery still wins. And this is SOS study. I think everyone knows about this graph. So what about bariatric surgery pertaining to Malaysia? Later on, I will show you the latest statistics of our country's bariatric scene and the different types of operation that we have performed in this country. But just to go through, this is the typical categories of a bariatric operation. Whether we may or may not be using it, one thing. And obviously it has evolutionized over time. But of course, in Malaysia, the two commonest operations is still sleeve gastrectomy and gastric bypass. And at our center, we do single incision, reduced ports, and multi-ports. Everyone knows the mechanism of sleeve, purely restrictive with some metabolic effect. And of course, gastric bypass as well with the foregut and hindgut theory. And of course, Prof. C.K. Huang, popularized the sleeve and sleeve plus, which I think some of our bariatric surgery in Malaysia does. I think Dr. Tikfu does sleeve and sleeve plus, sleeve DJB and sleeve PJB. I think Andrea as well does it. I'm not sure Kiru or Vimal does it. I haven't done it. Obviously, because of the surmountable number of diabetic patients in Malaysia, we are trying to shift the paradigm from just purely weight loss operation, but also trying to solve a metabolic problem, particularly diabetes, as you can see in this patient. I've written many articles, papers on surgery for diabetes and a change of paradigm, which without doubt, from my experience, and now we are getting a lot of support from endocrinologists who just keep referring us for metabolic surgery, not bariatric surgery, metabolic surgery. And since Walter Porras actually described the impact of metabolic surgery, numerous papers have shown the superiority of bariatric surgery, whether it's in high BMI patients or even lower BMI patients, and also the superiority in reduction in subset analysis, and particularly metabolic disorders and ischemic heart disease, and reduction in cardiovascular accidents. We also have published several papers on diabetic alone, and basically if you look, it's pretty comparable outcome between Malaysia, Asia, and North America. So it's complete similarities. We also showed that super obese, we also done and published in super obese patient, and again the outcome is pretty comparable with other countries. So more and more papers we have published. So basically, this paper showed that if we are going to treat patient who is obese and has severe metabolic problem, the sooner the better. Okay, and we published along with Prof. C.K. Huang on the influence of Asian ethnicity, and I think you need to read this paper, but generally it just tells us that bariatric surgery works for everyone. Unfortunately, the Malay population, we did not submit enough, but I'm pretty sure if you look at our subset group, the outcome is much better than this paper outcome. So basically, we know that diabetes resolve with bariatric and metabolic surgery, but how do we predict? There are three different predictor, but we normally use in our center, we use the ABCD system, and we always check the C-peptide if patient has diabetes. It's easier to basically predict and explain to the patient the chances of resolution, partial resolution, or improvement. And which surgery do we decide? In especially patient with diabetes, we follow the Cleveland Clinic. And as you can see, this is the nomogram of the Cleveland Clinic. And in fact, it's online. We just can chip in the 4 parameters related to the diabetes, and we decide which one. And we're currently doing a study in validity of Malaysian population with diabetes, whether it is whether this is valid for Asian population using the Cleveland scoring system. Indication for surgery, I think we follow the American, IDF. Obviously, they have incorporated bariatric surgery in the algorithm of diabetic treatment. So you can see there. This is, again, as mentioned before, it works also in patients with low BMI, even though they don't lose as much weight as those with heavier patients. I think we were supposed to come up with the guideline in our supposed to be Selsma meeting, right, Mr. Vimal? But unfortunately, because of COVID, it has been put forward now to next year. So we'll have a new bariatric surgical guidelines coming up then. Obviously, you know, it's a very safe operation, and obviously it's very cost effective, as mentioned. So the earlier we do, the more money we save, and these operations is as safe as you know, laparoscopic cholecystectomy, as long as you do in high volume center, of course. So last of my slide series is basically just to go through the current state in Malaysian bariatric scene. I think, you know, Malaysia first performed its bariatric operation back in 1996. I think Taiwan did the first in 1974 in Asia. This is the general statistics back in 2017. Nearly 100,000 Asians underwent bariatric surgery. We even published the history and progress of bariatric surgery in Malaysia. The milestone of bariatric surgery in Malaysia first performed in our hospital by Prof. Frida Mia, and followed up. In fact, our Director General of Surgery did the first laparoscopic vertical banded gastroplasty and sleeve gastrectomy in 2003. Mr. Vimal did the first, actually popularized bariatric surgery in the northern region of Malaysia. We established my MBS, me, Tikfu, and Hisham. So this is the indication for Malaysia. This is the remuneration and reimbursement for Malaysia. This is the current state of the number of bariatric surgeons in an institute in Malaysia in 2019. Because I did, you know, every year I have to collect all these data and present at, this one was presented at the Chinese Metabolic and Bariatric Society recently in June. So we have a total of 34 hospitals that perform bariatric surgery and 38 bariatric surgeons. So this is the comparison for between 2017 and 2019. These are the different types of operation that has been performed in this country by different surgeons. And you can see the number has increased quite significantly. Last year alone was 2,068, but I predict in 2020 statistic will be down because of COVID, unfortunately. This is our center. We have done to date 1,800 surgeries, but since 2012, you can see the exponential rise. So last year alone, we did 389 bariatric operations. This year was suppressed a bit because of COVID, but so far up to 1st of October, we have done 185 bariatric operations. So since 2012, we have done about 1,557 bariatric surgery, excluding balloon procedure. So this is how referral patients comes to see us. This is the overall laparoscopic procedure done in 2019, different types for the whole Malaysia. Still, laparoscopic sleeve gastrectomy is still the highest. And you can see the number of bariatric performed since 1996 in Malaysia is 5,900, so nearly 6,000, but you can see the exponential rate of growth. So this is just the key and growth areas challenges ahead, but in general, in summary, I think the number of obesity is increasing. Metabolic problem is a serious problem in this country with the COVID issues as well. You know, we just could not afford to be obese. There's no doubt that bariatric surgery and metabolic surgery result in the best outcome for this patient. So with that, I thank you for listening.
Thank you, Prof. Nick. That was very enlightening and very nice. We hope that with this webinar and with those listening in, we'll have more people interested in bariatric surgery, and definitely they will seek you for advice, for training, and for further development. So I think we will move on to...
just before that, Gafur, I would like to thank Prof. Nick for participating, because I heard that he will be leaving. There's a clinic to run, so thank you for participating.
Thank you, Prof. Nick. Thank you so much.
Okay.
So our next speaker is Dr. Kirubakaran Malapan. So Kiru actually qualified from did his MBBS in India and his MMed surgery in USM. He has a fellowship in bariatric and metabolic surgery from none other than Professor C.K. Huang in Taiwan. I think he was one of the first fellows to visit Professor C.K. Huang in in Taiwan, and completed the program. Besides, after finishing his fellowship and his subspecialty, he proceeded to set up the bariatric and metabolic surgical unit in Hospital Raja Permaisuri Bainun, which is Hospital Ipoh, which remains today to be one of the few government facilities that offers bariatric surgery. And his helm there has been taken over by none other than Dr. Mark, who is doing a very good job over there. A very good friend and a very good mentor. I think his only fault is he supports the wrong football club, which is Liverpool. And it gives me great pleasure to invite Dr. Kiru to present his talk on a non-surgical weight loss option in the COVID-19 pandemic era, and option to be considered. Dr. Kiru, please.
Yeah, thank you very much, Dr. Ghaffur, for that kind introduction. I hope you all can see my slides. Yes. Okay, so thank you very much to Selsma for giving me this opportunity to share a topic that I'm very passionate about, which is bariatric surgery. And as bariatric surgeons, we all are very used to performing surgery. But I think during this pandemic period, we are in a pandemic of obesity in Malaysia, whereby 1 in 2 of our population is either in the overweight or obese category, and suffering from obesity and its related complications. And many of you will see that last week, DG had announced that the case of COVID-19 cases may be rising. And true enough, within 6 days, we had 691 cases, which was the peak after our MCO was lifted way back in May and June. So this is causing a lot of panic, a lot of uneasiness, because we don't know the direction. The cases could be increasing and so on. And as Prof. Huang showed in Taiwan, it really didn't affect them that much. But in Malaysia, as Prof. Nick has shown, the number of cases did reduce. And of course, the resources will be moved away from important surgeries to try to stem the pandemic by cutting down on services and so on. So a good intervention for weight loss would be something that is healthcare professionally directed. There is doesn't deplete the resources and stretch our services as well. And it we can actually use this platform as well, like telehealth and so on. Doesn't require admissions, and of course, following the guidelines. So if you can see the treatment options that we have available for managing obesity, it's always BMI centric or comorbid centric. So in BMI centric, we always say that for surgery, anything BMI 32.5 and above with comorbidities or 37 will be eligible for surgery. But in those overweight as well as obese class 1 category, Asian criteria, where obesity begins at BMI 27 and above, we do have other interventions, like example, the intragastric balloon, meal replacements, as well as other interventions, including medication. And this is where I find it quite interesting, because the ASMBS has a guidelines that has been, or a position statement on the intragastric balloon, which is endorsed by SAGES as well. And I think we will be adopting this soon one day as well. And as Prof. Nick said, we have a new balloon that is available in Malaysia. I think most of us surgeons are quite used to the different types of gastric balloons that are available. And most of them are deployed by using endoscopy. But here we have a balloon that for the first time doesn't need a procedure, doesn't need surgery, endoscopy, or even anesthesia. And that is the ellipse balloon. And this balloon, as you can see, as a capsule, it just fits in the palm of my hand. It is connected by a thin catheter, and it is easily swallowed under fluoroscopy. So it's done in the X-ray department, and the person or the patient just has to swallow the capsule. And once it goes in, using 550 mils of fluid, a specialized fluid, it actually fills the balloon, and this induces the phenomenon of satiety. So basically, a balloon functions by restriction. So you actually reduce your intake of food and your caloric absorption and so on. And also it increases the gastric emptying time staying longer in the stomach as well. And it only remains there for about 4 months. That's the beauty of it. And by 4 months, you don't need to do a scope to remove it or puncture it. It just passes naturally through the GI system and comes out in your excretion after 4 months. So the gastric balloon offers an option for patients who have failed attempts at weight loss, who want to jumpstart their weight loss goal. For example, if you want to go for bariatric surgery, but your BMI is probably too high for surgery, or you want to take some time for that, then probably you can opt for a balloon. You want a short-term weight loss solution because you intend to go for a knee replacement or some fertility options in patients with full PCOS, or even if you don't qualify for any bariatric surgical option. And for those who do not want surgery, then this is a good option for them as well. So the ELLIPS program has to be done in a center which has a multidisciplinary approach to managing patients with obesity and bariatric surgery. So most of our centers shouldn't have a problem because we have all the important personnel involved, like a dietitian, the bariatric nurse, case manager, physiotherapist, psychologist, and so on. And here, I would just like to talk about the overview of the program. The first visit by the patient is actually the pre-placement, where we counsel the patient regarding the eligibility, the screening, the full dietary assessment, motivation goals, and so on, and starting the medication just before you go in for the procedure. And we have a checklist that we actually can go through and see. Of course, just like any bariatric procedure, the patient has to be 18 years and older. A BMI of this checklist was actually designed for patients by Elorion for using the Western criteria, Caucasian criteria. So for our patients, we can accept them for the balloon at a BMI of 25 and above. And of course, they shouldn't be pregnant, shouldn't have any history of surgery. And as I mentioned, the procedure can be done for an individual by just swallowing. So by going through a detailed history, the patient actually doesn't need an endoscopy. However, if they have strong history of reflux, gastric problems, some abdominal distension, then they should be investigated further by doing an ultrasound, doing an endoscopy, making sure that the stomach is should be easy to proceed with the balloon placement. And of course, certain medical history like swallowing disorders, bowel obstruction, Crohn's disease, and so on, totally negate and shouldn't be placed in these patients as well. Now, the procedure is done on the second visit. There is a placement day. The patient normally changes, goes down to the X-ray department, and under fluoroscopic guidance, patient just swallows the balloon. This was in the initial phase, as you can see in the picture. Actually, I was in the room with the patient itself. Nowadays, I'm outside of the room, and we can actually observe by fluoroscopy the position in the stomach, and we deploy the balloon. Now, at months 1 to 4, the whole concept is having your team together with you to diet the patient, to give them the explanation, the lifestyle change. And this behavior change is the focus to the long-term management in the weight loss. So after 4 months, once the balloon has passed, we still continue the support. We keep in touch with the patient through our phone contact as well. And as you can see here in the gentleman, prior to his ELLIPS placement, he weighed about 110.3 kilos. That was about 29th of June. And we just had a follow-up for him just a few days ago on the 7th of October. And he found that in 3 months, he has lost about 17 kilos. So I'm quite happy with the weight loss that we are seeing. Again, we are still early days in our this one. We have not done many patients. We've just done about 10 to 12 patients in the program. So we hope to have our data up and we hope to report it as well. So the novel thing about this device is the device, the balloon itself, the design of it, and of course the material. It's very easy to swallow. Okay, although it is about the size of about 2.5 centimeters. It's vegetarian capsule, so it's acceptable to everybody. The delivery catheter is very thin, so you don't actually feel it like an endoscope in your throat. The device itself is made of polyurethane. It's very thin, it's very flexible, as you can see, very malleable, and it sits very comfortably in the stomach as well, and made of durable material, so it doesn't react with the hydrochloric acid. Now, the innovation of the device is that there is a release valve in the superior part of the balloon with a thin hole, and it's exposed on the inside to a degradable filament, which is in contact with the fluid. So it weakens over time, and exactly about 4 months, take a few days, the filament weakens and it opens up and allows the fluid to actually all pass out. Now, there is a fill valve here that you can see on the outer aspect of the balloon itself. So when the catheter needs to be removed, when you pull it, it seals shut completely and it doesn't allow the fluid from inside to actually seep out. So it maintains itself in the stomach. Now, many of y'all will be wondering why only 4 months? Why didn't they design the balloon for 6 months or even a year? Well, this is an interesting study that was presented by Gaur et al. In GI endoscopy, which actually shows that 80% of the weight loss of a 6-month Obera balloon occurs in the first 3 months. So you can see here the weight loss for about 3 months occurs to about 12.9 kilos, and the weight loss at 6 months maintains about 16 kilos as well, and the percentage of weight loss is about 80%. So it doesn't make sense to create a balloon that lasts longer than that, because this is where we will see the maximum efficacy at the 3 months placement, and slowly it actually maintains over that period as well. Another question that a lot of people will be asking is, a screening endoscopy predictive of a balloon intolerance, and that will probably necessitate for the patient to remove the balloon. So again, in this Obera study, we have 303 patients who were treated, and 25 of them had balloon intolerance and had to have that have it removed by endoscopy. And this amounted to about 8.25% of the treatment population. Now, on screening endoscopy, it was noted that patients had esophagitis, gastric erosions, gastritis, hernia, H. pylori positive, as well as chronic gastritis. But in none of these patients that were found to have this disease, none of them actually were able to be predicted that they had to remove the balloon or had any intolerance. In other words, the patients who were diagnosed with these diseases did not have the balloon removed, but the patients who had the balloon removed developed this disease pathology somewhere during their treatment time. So in clinical studies, it has been demonstrated that the patients will lose to about 13 to 15 kilos of total weight loss with the balloon. So this is across the board. We are seeing some patients who have lost a little bit more, some who are a little bit less, but generally we can quote that patients should lose about 13 to 15 kilos. Here I will share some data from some internationally presented studies that was released in April this year in obesity surgery. Consecutively, 1,770 patients had the ellipse balloon treatment going on from January 2016 till 2019 December. And as you can see, mostly were female, about 2-to-1 ratio, and the weight was about 94.6 kilos plus minus 18.9, with a BMI of about 35, with comorbidities relating to hypercholesterolemia and a HbA1c of about 5.1. Now, you can see that about 1,133, that's about 64%, were able to swallow the capsule, whereas 636 of them, or 35%, needed a stilette assistance. Now, a stilette is basically something that is inserted into the catheter to stiffen it, to be allowing the patient to be able to swallow it with a little bit of gentle pressure by the operating surgeon. Now, in placement failed, there was only one patient who couldn't tolerate swallowing the balloon or the placement with the stilette, and the procedure had to be abandoned. Now, in about 95% of patients, the balloon is passed out in their stools. About 0.6% vomit out the balloon itself, and about 3.6% required endoscopic removal for any cause, either because of developing of pathology, pregnancy, and about 0.02% of them required surgical removal. As you can see, in terms of triglyceride improvement, LDL improvement, HbA1c improvement at 4 months, all of them were statistically significant. Were there any adverse events and complications? Yes, there was about 2.9% of them required endoscopic removal. The rest of the other complications were less than 1%, making it a very, very safe device. In conclusion, this demonstrates the safety and efficacy of the ellipse balloon. It's easy use. It gave a 14.2% of total body weight loss, which is comparable with other gastric balloons in the market as well. And 3 patients had small bowel obstruction, which occurred in the year 2016 with the earlier version of the device. Since then, 2017 until now, 2020, there has not been any more small bowel obstruction cases reported. Now, in terms of long term, after 4 months, if you compare the same patients at 12 months of balloon removal, you find that the maintenance of total body weight loss in 3 studies has shown to be approximately 72%, 93%, and of course 95%, making it quite long lasting at 1 year. Now, how about putting the balloon and repeating another balloon after 6 months? Well, there's a sequential study that was done in a small number of patients, 30 obese patients. The treatment started before the ellipse placement. They underwent the balloon placement for about 4 months, after which it passed out through. 2 months they were without the balloon, but they were still under diet control. They were still counseled and so on. And the second balloon was placed in. And again for 4 months and a follow-up 1 month after that. So what happened to these patients? So again, 2-to-1 ratio of patients. The weight was a bit higher this time, about 101 kilos, with a BMI of about 37. Now, the weight loss in these patients was about 12.7%, the total percentage body weight loss. And with the second balloon, it increased. The weight loss was not as much as 12, but it was about 8.2%. And this gives weight loss of about 20%. Again, there was no adverse events, and one patient had to undergo a planned removal because patient developed a history of appendicitis. So a sequential balloon treatment is again safe, and it can improve the weight loss to about 20% with no serious adverse events, and patients are quite good at follow-up as well. Now, we have placed the balloon in the last 3 years until December 2019. This is the adverse events reported by Allurion, and they found that about in 21,381 balloons worldwide that has been deployed, the complication rates are all less than 0.5%, which is making it a very, very safe device to be deployed. So with that, I would like to thank you for this presentation and say that in these times of uncertainty, a weight loss journey can kickstart by using an ellipse balloon, and later on, as things improve, we can continue with our bariatric surgery and other modalities of treatment as well. But having said that, now with the number of cases reducing, I think we have a different treatment option available for all our patients. Thank you very much.
Right. Thank you, Dr. Kiru, for that talk. Definitely is very informative, something new to our Malaysian population. So we'll probably take all the questions later. So let's move on to our next speaker. He's Dr. Tikfu. He's one of the pioneers in bariatric surgery here in Malaysia. Dato earned his medical degree at the Karnataka State University, India. And after completing his master's degree in surgery in University Malaya, he went on to specialize in the field of minimally invasive surgery and bariatric surgery in France. And later had his surgical training in Paris. Dr. Gies has contributed numerous publications and medical articles in the field of surgery. He has been featured on a few local papers, magazines, and radio. He has also been given various talks in conferences and seminars, both within the country and abroad. His most recent honor was a Best Clinical Paper Award from Asia Pacific Metabolic and Bariatric Society 2018, which was held in Japan. So with that, I'd like to invite Dr. Gi for your talk.
Thank you very much, Mr. Chairman, for your kind introduction. And thank you very much to the organizing committee to invite me to speak today. I'll be talking about bariatric surgery in Malaysia and what needs to be, so sorry. I hope you can see the screen. I'll be talking about bariatric surgery in Malaysia and what needs to be changed. Now, don't worry, this is not the end of my talk. Nothing will change. What I mean to say is that nothing will change if we don't speak with unity in a single voice and to try to lobby for certain changes to happen. Now, as mentioned by previous speakers, the trend of overweight and obesity in Malaysia is on the rise. Now, we have done a lot of prevalence study in Malaysia, and which is, I think, the National Health and Mobility study is every 4 years. And we actually look at the prevalence but we don't actually look at the incidence of obesity itself. It's estimated that the obesity rates in Malaysia is approximately maybe about 1%. So we actually increase obesity rates at about 1% a year. Now, this is based on the last National Health and Mobility Survey, which is in 2015. As you can see that the estimated population based on our total population in Malaysia, 30 million. Class 1 will constitute approximately about 4.5 million for population. Class 2 will be about 731,000, and Class 3 will be about 256,000 people. The question is, how many of us, how many patients are we operating on? We are probably operating about, at best, total in the country. I think Prof. Nick will be the best person to answer, but approximately maybe about 2,000 patients a year. So assuming that if it's about 2,000, we are actually operating about approximately maybe less than 2% of the obese population in Malaysia now, with an increasing rate of about 1%. And if we are operating only on 1% of this obese population, we are not actually solving the obesity problem. We are just maintaining the obesity problem. Okay, so this is the target group which will qualify for surgery as discussed. I'm not going to go further, but we're looking at about 1 million people at this current point in time. Now, this is an American study that actually looked at what are the Americans' perception of what they think is a safe weight loss method. And you can see that weight loss surgery actually constitute about 1/3 of this perception. What else? A dietary as well as diet and exercise is still the preferred method. This is something that we are all familiar with, and I think there are a lot of doctors are also very familiar with this pathway. People like to think that when someone is obese, we have to go through these levels, this pyramid levels, and that bariatric surgery as it sits lastly and finally on top. And we as bariatric surgeons know that this is not true at all, because this pyramid actually represents when the patient actually comes to you. If they come to you with a very high BMI, with metabolic syndrome, and you know that this patient is going to qualify for bariatric surgery, I'm not going to waste my time doing weight management or diet counseling, because we're going to be wasting his or her time. We're going to waste the patient's time. And when they have diabetes, and when they have comorbidities, and when they have a high BMI issue, diet and exercise is not going to help. A lot of them come here and even exercise because of their joint pains or their spinal problems. And we know that we are wasting our time, because for every month or every week that we waste, or every year that we waste, we are actually increasing their risk of developing myocardial infarction or stroke. And so this pyramid is true when we apply it to the context of what is the patient's BMI when we first encounter them. So do not be misinformed by this so-called pyramid treatment. Now, I have the advantage of working both in the public sector as well as the private sector. Pretty much like a lot of the panel right here, we have a chance to see both sides of the world, and both sides of these sectors actually have their own inherent problem. In fact, every different hospital in different states will probably have their own subset of their own local problems. But in general, I'd like to mention that this is a study again done by the Americans, and they wanted to know what the barriers to treatments are. And the first thing is the barrier to this treatment is from the patient's perspective, which is the lack of recognition of the disease. A lot of people do not see obesity and overweight as a disease. So if they don't recognize it as a disease, they will not seek treatment for it. So only about 10% of individuals with obesity in the US has actually been diagnosed. So there's a lot of awareness that needs to be created, especially among healthcare professionals. And when I talk about this, I mean people who are not in the field of bariatric surgery. They need to recognize obesity as a disease and not just as an image issue. The second barrier to treatment is that a lot of patients or even their doctors are unwilling to talk about obesity. Communication skills needs to be improved, especially from the doctors on how you're going to approach someone with obesity issue. And this is very true and very applicable to people who are in the general practice or who are in family medicine, and they're actually seeing patients with different problems. For example, they're treating their diabetes or they're treating their hypertension, and it's clear cut that the patient has a weight problem. How do you talk to them? How do you approach them? So more often than not, maybe due to lack of time, maybe there's a lot of patients waiting outside the clinic, or the fact that you just don't want to talk about it. The message of or the diagnosis of obesity is not being conveyed to the patient, and people are just not willing to discuss about it. Another barrier to treatment would be that, again, there are a lot of doctors or healthcare professionals, and when I say healthcare professionals, I do include the dietitians as well. Many of them feel that we must start at the bottom of the treatment pyramid, which is counseling and diet and exercise. And we all know that once you reach a certain BMI, or once you reach a certain weight, a lot of these conservative treatment strategies actually fail. And when it fails, and when the healthcare professionals do not talk about the option of bariatric surgery, a lot of these patients actually give up. They feel frustrated, and they think that there's nothing else that they can do to help them. Okay, so there are actually many other factors that influences this barriers to treatment. I'm just going to go through them pretty quickly, but I can categorize them broadly into three different factors. We have the patient factors, we have the healthcare professional factors, and we also have economic factors. So what are the patient factors? I think first and foremost would be awareness. Patient awareness is very low. And it's not just about patients' awareness about obesity. It's not just patients' awareness about being overweight. Let's talk about something that has existed a much longer time in our country, which is a big problem as well. For example, awareness about cancer, awareness about things like diabetes, awareness about hypertension, or even OSA and things like that. Our awareness level in this country is extremely low, and it's not easy to create a lot of educational programs for this population. Of course, those who are aware and those who actually look and seek out answers, especially on the website, on Google, these are the more informed or more educated group of people, and they constitute a very small percentage of the population. Of course, we have demographic variables as well. As you know, that the millennials and the newer generation of people are more IT savvy, and they're more aware about obesity and overweight issues, whereas the more older generation, or what we call the boomers and those in their 40s and 50s, of course, who rely more on things like conventional news, like newspapers and on a television show and all that, I'm probably less aware about obesity as a disease, less aware that there is a weight loss surgery option. Ethnicity as well as education does influence our culture and the way we think about bariatric surgery. There are beliefs, cultures, there are behaviors. Some people are afraid. You tell them to do surgery, they immediately put off. And of course, general attitudes towards surgery. What about the factors that influences the healthcare professionals? So I think one of the key things would be the training pathway of the bariatric surgeon. Number one, bariatric surgery is yet to be recognized as a field on its own. A lot of people and a lot of young surgical medical officers or even young surgeons are actually quite keen to take up bariatric surgery, but they don't know where to go, they don't know what to do. And the current only available pathway appears to be just the upper gastrointestinal surgery pathway. And some people are just not keen to do that upper GI pathway because they do not want to deal with the esophageal or the gastric cancer aspect of upper GI surgery, and they just want to focus on bariatric surgery. So this is one area that we need to look at, and as a society, as something that we need to discuss. Now, between surgeons and physicians, you're more likely to get referrals from surgeons. For example, the orthopedic surgeons will be more likely to refer cases to you because from a surgeon's perspective, they know that surgery has a risk, but the benefits outweighs the risk, and that and if your results are good, they understand that they need to refer these patients to you because it's more effective. The physicians, on the other hand, are more reserved, and a lot of endocrinologists still do not see the value of bariatric surgery, and they're quite reserved to refer patients for bariatric surgery. In fact, I get more referrals from Klinik Kesihatan and from general practitioners, those from family medicine, more than the endocrinologists. Yeah. Again, there's also differences between public and private healthcare professionals. If someone were to refer a patient to you, if they seem to benefit from a patient's weight, then they will lose the patient if they refer it to you. Unfortunately, there are still doctors who think that way, and so there might be a barrier to that referral. Of course, on the public side, the referral will probably be a lot easier because they don't lose a patient. In fact, it's easier to push the patient away to another department. So there are differences in the private as well as the public sector. Last but not the least, of course, we have something called accreditation. But first and foremost, we must have enough bariatric surgeons, and we must have enough centers before we can even think about accrediting these centers. The last factor to be discussed here would be the economic factor, and I think this is a major factor involved. There are patients who are well aware, there are centers which are ready to perform the surgery, there are skilled surgeons who are ready to do the surgery, but there's no money. And bariatric surgery at this point in the public sector is not exactly very well supported. If it's a government hospital and if it's a department of surgery, your funding actually comes from your peruntukan for the entire department, and you receive a part of this department's peruntukan, and you have to use it wisely. Whereas if we are talking about the public sector or private sector, of course, then we have to talk about self-costs. So one of the key things that we can tell our patients is that you have to think about this money spent as a long-term investment. And as what Prof. Nick had mentioned earlier on about the treatment costs of various medical conditions can actually be a lot higher than performing or getting a bariatric surgery done. Insurance is a very important factor in the private sector. 90%, up to 90% of a lot of surgeries performed in the private sector are funded by medical insurances. That depends, of course, from hospital to hospital, but in general, that is the percentage of the coverage of the cost of the surgery. So at this point in time, insurance do not cover bariatric surgery, and it is an area that we need to look into and discuss. Government hospital funding, like I said, it will be very difficult because the government or the Ministry of Health will probably have their priority, and the priority at this point in time is definitely not obesity. Even there's no political will to think about obesity as a disease. The government still subsidizes rice, flour, sugar, and oil. So when you subsidize these 4 ingredients, you're going to get a lot of street food and a lot of cheap food that is made from the combination of these 4. So with fried carbohydrates like chikodok, for example. So you're gonna get a lot of this type of food, and that's going to lead to a lot of obesity. If this subsidy were channeled somehow to patient education, awareness about obesity or bariatric surgery treatments or obesity treatments, then there will be a lot more surgeries being performed. But if politicians were to remove these subsidies, then they're going to lose the election. So they're not going to remove the subsidy for rice, that's for sure. So we still have to wait for Dr. Ghaffur to do something about that aspect, but we'll talk about that another time. Yeah. So what's the action plan? I think this is the last slide that I have, and I think these are the key things that we need to look at from all the factors that we discussed. First, we need to raise public awareness. So we need to have some education program. We need to have some campaigns, some roadshows about obesity and what weight loss surgery is all about. It's not as scary as it is. We must use the media and the social media to propagate this message. And I think the next speaker is going to talk a lot more about this. We need to change the current perception about obesity and overweight. A lot of people still don't view obesity as a disease. They need to know that it is a disease. And the treatment, one of the treatment and the most effective treatment is weight loss surgery. We also need to change the perception of surgery, and it's not just the perception of surgery of the public, of what they think what surgery is, but we need to change the perception of surgery among surgeons. We should not promote and market bariatric surgery as an aesthetic procedure. We must stop doing that. People must not think that we are doing this for image reasons. The point is that if you do that, it's not going to solve the root cause problem. They're going to come back with weight regain because they do not understand what this surgery is all about. And a lot of patients like to think when they do it for aesthetic reasons, they like to think that bariatric surgery is going to prevent them from ever getting fat ever again, and they can do whatever they want. So that's extremely wrong, and I don't want to go in that direction. We should not go into that direction because we're going to invite a lot of problems in the future. We need to raise awareness among the healthcare professionals. We need to have more CPGs We need to have more programs to tell them how effective bariatric surgery is. And I think one of the key things that we need to do is to publish local data and to present them and to let our physicians and our local doctors know that we do have very good results. And this includes resolution or remission of diabetes. And of course, training pathway and the availability of bariatric surgery and bariatric surgeons, especially in every major city in this country, in the government sector, will definitely help to increase the number of bariatric surgeries performed as well as the awareness. Yeah, and maybe we can look at screening programs at some point. Like I've said, raise more patient education, some roadshows, and we can have more screening programs and let people know that this is your body composition, this is your fat levels in your body. We need to do something about it, otherwise you're going to increase your risk of other comorbidities. Yeah. Government funding and subsidies is something that requires a lot of political will, and it's not exactly on the priority of any government or any political party at this point in time. Yeah. Thank you very much for your attention. I don't have before and after photos to show because of my topic. I just want to make a comment about Kiru's before and after photo. I can see that there is a significant weight loss of the surgeon rather than the patient. So I don't know who's the patient, who's the doctor, but anyway, thank you. Thanks for your attention.
Thank you, Dato, for your talk. It's indeed an eye-opening talk, and I'm pretty sure everyone feels the same, that this thing is a problem for us. We are there in the fog now in this part, and something that we all really need to address probably in the near future. Thanks again, Dato.
Okay, thank you.
So let's move on to our final speaker, Dr. Mustafa Mohammed. He's a medical doctor specializing in general surgery and upper GI surgery in Ampang, Malaysia. He's currently practicing at KPJ Ampang Puteri Specialist Hospital and was a surgeon in University Kebangsaan Malaysia Medical Center. He'll be giving a talk on marketing bariatric surgery in Malaysia. Over to you, Dr. Mustafa.
Mustafa, your cap also is the advertisement. You're the perfect person to talk.
Okay, hi everybody. I think I am the last to talk here. Nothing left for me to talk, everybody. I think Dato Nick, he's already mentioned a lot of things that I'm going to share as well. Dato G also, thank you for helping a lot to clear up the stories that we need to talk. Okay, my topic, maybe I have to talk in a different way just to soothe out what is happening for the bariatric and how to market it out for, I would say, like for national and international level. I will still believe we undermarket ourselves for the whole Malaysia as a nation. And unfortunately, there are a lot of missing data that is actually doesn't represent what is happening in the real field. And I believe for the last, let's say, 10 years, maybe, we've been doing a great job, but unfortunately not great enough to share with the whole world. And this is what we are going to talk. I think it's already well, I'm not going to go for all this because everybody is mentioning about it, our population, and then the obesity, that how much we have. And unfortunately, we are winning all the skills that between the Asia and Southeast Asia, and been published that obesity is come to be like number set towards the first problem. But when we come talking about not for the adults, we are reaching also to the now for the childhood. Now, for all the studies actually show that in 2019, NHMS is actually showed that rising trend in weight and gain, that 50% of the adults were 30% of them they are overweight and 90% of them they are under obesity. And this is particularly when we talk about women and unfortunately we are talking about the middle age. The problem is the culture belief, the human beliefs that you are in a certain age is good or acceptable to be like an overweight or obese, and that's maybe because of pregnancy and so factors. But now what we are talking about, the risk when we start to see this is actually even escalate in the children. Okay, Malaysia, very rich country with all the type of food, is a multi-ethnic country. You have all the type of food, and is a privilege that you have everything is easy and available and over the day, 24 hours, and people, they don't believe it. I was one of them when I came over. Actually, I couldn't believe how easy to get food here. I gained weight for a while, but able to control myself. Okay, let's go beyond that. Okay, where the journey begins, I think is already Dr. Nick just now, he already mentioned that when the first surgery in 1996 performed by Prof. Mia, then followed by Prof. Jasmine, Prof. Hisham, all those doctors. Mr. Vimal, he is one of those pioneers. I see that he is enjoying his life now, but still we are not sharing enough that what's been done so far. Dr. Tikfu, when established and was the president of my MBS, okay, the number of cases escalate, which I believe has been there, but we didn't present it very well with the different varieties of the surgery. But what we have to really share, are we doing enough or no? That is actually what I'm going to advertise for it in a different way. Okay, what have been done? Okay, so now, how we are going to present ourselves, how we are going to pass this to the culture, how we are going to pass it to the nation. So it starts from the level of education, it starts from the roadshow, it starts from the social media. I believe in social media. This is a very strong weapon. Some people, they may take it in a way, some people, they can take it in a very scientific way, but you believe it or don't believe it, is actually Asia is considered the highest country in between all over the world in browsing of the social media. So the accept and the people accepting for this tool as a main source for advertising is actually very wide. Might as well we just make use of it. I think there's already Dr. Nick, he showed this, the principle of everything. We have to collaborate between all the levels, both Ministry of Higher Education to the Ministry of Health. Unfortunately, the private sector was not presented in this CPG meeting in a way. What we've done, okay, we created a lot of programs, which I'm talking now precisely mixture between the private and the public. We started this HOPE program. What is this HOPE program? The idea between HOPE program to help those people who they don't offer to operate, they are not in the government panels. Even sometimes when you have some type of surgery which is on the very bargain price in the government, but people, they cannot afford it. So we created this HOPE program. HOPE program is mainly actually to do bariatric surgery for these people who they don't even offer to pay for the admission for one night in the hospital. Yes, the idea behind it to have a free surgery, but actually those type of patients, they have to go through panels a lot. Thank you for all the companies, the vendors, from Johnson & Johnson, Medtronic, all those people to help us with the hospitals as well to create this program. And so far we're able to do a few cases on free basis. And this one actually, because of the privacy, we didn't publish it, but soon, hopefully, I think within a month of December or early January, we are going to make it on the social media and even on all the social panels. So maybe we can help more people to do this surgery, even in the private sector. So we just want to mix that collaboration between the both sectors, and that's maybe it will end with some better outcome for patients. FinTech is actually as an easy installment plan. We did a plan with the AM Bank. The idea behind it is actually you get an individual bank loan on basis of 1 year, 3 years, 5 years, and 9 years. There is a mild interest fee from that, but it's actually, this is something between the patient and the bank, as if you are buying a car or loan or something like that. Yes, of course, it's have to be individualized patient to patient, but able to do some of these cases because this program just launched end of last year. Right. We did a lot of education program with Johnson & Johnson, with the endocrinologists. We able to use some of those celebrities who already, this is actually showing the picture, one of the celebrity chefs who done a surgery 2012, gastric bypass, have a very stable weight loss. And even we show how to do in the surgery, the cutting. We did a session of hands-on, and it's already been shown in the newspaper. We've done this even not only in one language, we've done it in Malay, in English, and even in Chinese as well, and in Japanese as well, because you have a lot of aspects here, and those people sometimes they don't know what it's all about bariatrics. So we go all the way even to the different nationalities. Now, I think this is everybody concerned, and mainly for us when we are, because I'm now serving more in the private sector. Why not the insurance in Malaysia should start covering bariatric surgery, which I believe we didn't have enough approach to this. Although I know in 2016 or 17, there was a trial, and we bring one of the pioneer surgeons from India and Taiwan, and we try to present to them with the company Johnson & Johnson in order to try to get an approval with it, but actually is went to a different level now, which I believe this is the right time to start to talk about obesity management, cost effectiveness. And I believe there are a lot of studies that have been done in the UK and the States, which show basically, as been mentioned, that treating patients with a single shot bariatric surgery, cost effectiveness why is actually much better than treating all the comorbidities is come from the obesity. But I believe we didn't do enough in order to show that. And it is the time to really represent this to the, maybe we can unite together and unite together and try to represent this. Maybe we can get something behind it, right? A lot of programs, we use our ex-patients in order to, I'm not a fan here of Johnson & Johnson. I see all the picture looks like Johnson & Johnson, but these are some of the things that we went through. Mission Impossible, it is possible. And we actually was the idea behind it is actually how to support the patient. And so we collaborate from our side and share our patients to be part of these events as well. We created a lot of My Health program. This is actually a program. It starts from the cooking, it starts from the training. We put a lot of celebrities as well. The idea was behind it. This is actually a 2.5 days program. Is actually to not only about weight loss, if bariatric whatsoever, this is about for patients who are pre-op, post-op, even normal people, how to educate yourself about how to maintain your weight and so forth. So we include all those type of people. They are all in this field, from training to the dancing to the cooking and to acting and so forth. All right, we reached to out states, we reached to Oman because they have a lot of obesity, and we try to show Malaysia as a hub for the health tourism, and able to get some few patients from Emirates, from Oman as well. Brunei is a big target for us as well, because it's facilitating. We've done good number of patients as well, a lot of visits. We met with the Minister of Health. We reached to the islands, Tuvalu, which is actually an island is next to Fiji, and able to bring them over. We operated all them here. We've done a lot of programs on TV. Nasi Lemak Kopi. This is actually one of the programs, which is, yeah, the name is actually doesn't really represent, but it's actually talk a lot about health as well. We did a lot of a training program, and also on the TV on different channels as well. We get a group of bloggers. Those bloggers actually, each of them is actually, they have their own channel on the YouTube. They are all YouTubers, and those people actually help you to reach different type of the society that you even never know about them. These are one of the things. We've done a lot of, this is one of the Italian magazines that is actually concerned about the aspects here. We reach even to the Arab magazines as well to give a lot of talk and education about the healthcare here. We did a lot of healthy cooking with this one of these celebrity chefs, cooking a lot of healthy food, helping the people to understand how to contain about your healthy diet daily. We did a launching training program with this is with the Taher actually. because actually they have this training program when we have KL a free day with with the Sultan himself. So we did this a training program as well, launched by the Sultan himself from Kedah, but it was in KL as well. We get a lot of we get this award about the best health bariatric center as well. Set the records. We're able to reach the number of the cases from 1 to 2 to 5 cases of between the sleeve and bypass in one day. Invited a lot of these pioneers. This is one of the people that I trained with, Dr. Liu J, but this is a training program was in UKM. And of course, I'm not showing actually before and after, but this is just to tell those are the influencers that we able to achieve our market to hit the social media, singer to the actor to another. This is an Indonesian actress, is also a very field. I think this picture are also shown by Dr. Nick just now, and we reach even to 320 to 350 kilo. Out of all this, I just want to summarize the things. What we need to have more collaboration between the government and the private sector. We need to find more financial solution for those people from the low socioeconomic class. And we do believe that obesity is a disease for the low socioeconomic class people. We need to approach the insurance companies, at least even in countries like even in Hong Kong, even I think in Taiwan, they have 50% coverage as a starting. Country registry, this is something that need to look for it, and because this can represent what we are doing here. CPG is a kickstart for the proper bariatric program and management. We need to emphasize on more awareness program from the food and the lifestyle. And I believe that in collaboration as international training program, it is the key for all this. I don't think I have more to talk about, but I think marketing, it will start from representing ourselves by all means. Each doctor that have his own field, but you need to do what you think it is suitable to you. Still, social media is a good field, but other than that, the scientific base is still number one. That's what we have to collaborate. Now we have 3 sectors that we need to collaborate: the government, the education, the higher education, and actually the private sector. I think by this, I would like to say thank you for the invite, and hope that we can do more for our patients. Thank you very much.
Hey, thanks, Mustafa. I think we should all have another webinar only with you. I think, Mark, maybe you start with some questions first, Mark, the one in the panel. So we have...
Okay, we got a couple of questions here. So first one, how much is the cost of the intragastric balloon as compared to sleeve gastrectomy? Probably Dr. Kiru can enlighten us.
Thank you, Mark, for the question. I think it's an interesting question, but the problem is the intragastric balloon is it's a non-surgical option. Of course, we're talking about comparison between an apple and an orange. So the ellipse is anywhere between maybe around 13 to 15,000, maybe slightly higher, because it's going to vary from institution to institution. And similarly with the cost of sleeve gastrectomy can be anywhere between, I think it's somewhere from 28,000 to about even 36,000. So this is the difference in the price range. I hope that answers Mark.
Yeah, I think it's slowly making its way into the government sector.
Yeah.
And then probably slightly cheaper. Like
related to the ellipse, anyone of the panel, we don't know the main problem. You see, if you compare Taiwan with Malaysia, both similar countries, maybe we have more obesity, but we are so far behind in terms of surgical treatment of obesity. Okay? So maybe it is due to education. So this is where we are lacking. They are already reached, Taiwan has already reached a level of education where the patients come in and request for procedure. Okay, they are already second generation, third generation, and so forth. We are probably skimming the surface, trying to reach the first generation, and then we are hampered by lack of insurance cover and national health policy to help the obese. So, in this scenario, do you think a balloon, which is acceptable, safe, easy to put, and doesn't have much complication as the previous balloon, will help to bridge this gap, get patient into the scheme of things where they really want to go in for some bariatric procedure?
Yeah. Thank you, Mr. Noah. I think it's a very good question, because when we, with all the data that our speakers have shared as well, we know for every one patient who comes for bariatric surgery, there are at least about 10 who are in the overweight and obese range who probably are not keen for a surgical intervention. So by having another tool in our armamentarium that we can offer to patients, I think this is a good opportunity to offer a treatment option like I presented earlier. We can use this as a bridge for patients to lose weight, and looking at that, while the image of bariatric surgery improves in Malaysia with a lot of work that all our speakers are doing, as well as what Mustafa has shown, awareness is increasing. In this time of a pandemic as well, where people are a bit reluctant to come to hospitals, we have a solution that probably is not as stressful as surgery, but you can achieve the result. If someone who wants to lose 10 to 15% of their body weight, I think this is a good option as well. And yeah, like I said, it kickstart your weight loss journey. And probably when people see that there's a momentum going and so on, then I think it will pick up, and we have solutions for patients across the board. How about all the other panelists? What do you all think about it?
I think the patients need to be aware that number one, as what you have mentioned, the balloon is definitely not a surgical option, and it's the difference between an apple and a pear, like what you said, an orange. But we cannot compare. We cannot compare with surgery, and they have to understand that balloon is a temporary method, and the weight loss is very, very modest, actually, like what you said, about 10 to 15% of the weight. So as long as they understand that and they are too afraid to go for surgery, it will remain to be a good second option other than surgery.
I think we have another
Personally, I think the balloon is good for those class that overweight, no medical problems, or some medical problems which give them to lose weight they can't do by the usual diet and control, exercises. So the balloon is okay. And that, like I said, maybe it's a bridging procedure. Also, for you to get the question into your system, is my own personal opinion.
There's another option that you can think about, which is a medical option, which is using something like a GLP-1 agonist, like Saxenda, apart from the balloon. So that is also a very viable option where nothing is being placed in your body except that you just need to inject yourself medication.
It's a good option.
What about a combination of the two, the GLP-1 agonist with the balloon? Anyone have any experience with it?
I think maybe Mr. Vimal?
Oh, Dato.
I think in theory, of course, the combination is very viable, because one targets restriction, an anatomical restriction, whereas Saxenda would target the appetite. So even if you have restriction with the balloon alone, you may still have the appetite to eat. It's just that you feel full faster with the restriction. But if you have a combination of both, then you're able to probably achieve a greater weight loss. There are no studies that's been done so far, but in theory, it does sound viable. Maybe Gaffer could think about doing something like that.
Yeah, I have actually one patient who was started by with a GLP-1 analog. Actually, he lost about 7 to 8 kilos. He did quite well with his lifestyle change and so on. But once he hit the plateau, he was not keen in continuing the medication alone, and he wanted something which was non-surgical. So we put in the balloon, and in a space of 1 week, he has lost about 4 kilos, and his weight is going down. So I have a feeling these options that patients can have, to move from medication to temporary option while getting the information and confidence in doing bariatric surgery. And I feel that all this will give confidence to patients, and I think as long as they have different options available, I think we will slowly see a lot of treatment options available for people for obesity.
But likewise,
I think
those who fail,
sorry.
those who fail with the balloon will also have a very negative outlook of bariatric surgery because they've lost that confidence as well. So I think the patient expectation is very important. How you prepare them mentally about what to expect. That makes a big difference.
I totally agree with Dato G. I mean, when we talk about this type of alternative procedure, number one and last is actually how to prepare the patient. They should have what is the anticipation behind it. Sometimes people, they think this is actually, it is head to head when you talk about gastric balloon, but it is not the scenario at all. I think this is all individual when you want to combine between two types of methods. Now, it is all how you set and what it works for your patient. But as we mentioned, bariatric when it's reached, when we are talking obesity class 2 and above, then this actually is not the option to waste for the patient. They have to understand that very well. Now, this is what we have to pass the message, because a lot of people sometimes when they have this negative input about bariatric, but they have to understand you are talking about here ultimate solution. I still believe it is how to prepare the patient, because all this, what you call alternative weight loss, it is too much depend on the patient. That's why we see some patients, they can use 3 kilos, sometimes they can use 10 kilos, but there is no standard for this.
Okay, I think we have another question. I think Kiru, I think you can answer this.
Yeah.
What if mechanical failure happens in the ellipsis balloon? I think maybe he's referring to the fact that if there is a leak or you are unable to inflate the balloon for some reason, have you encountered this in your research for this presentation or something like that?
No, because so far we put in about 10 to 12, I think about 12 balloons so far, and we never had a problem of mechanical failure in terms of insertion. I think the question to me, I think it sounds like if patient has some problem, how can we remove it in between? Just like all the other balloons as well, you just do an endoscopy and you just puncture the balloon and you can take it out. You need the puncture needle and as well as a grasper tripod to pull it out. So it can be removed at any time, shouldn't be a problem. In terms of device failure, I'm not sure. I think you have to contact the distributor, and I think if you have any is not able to deflate to inflate or anything like that, I'm sure they will replace like for like, so it shouldn't be a problem.
Okay.
Okay, there's another question here for Dr. Kiru. All patients before procedure, do they have to go for scope first to assess their stomach?
Yeah, Mark, I think that's a nice question, because you know why? Because they have put in so many balloons overseas, in Europe and US. So according to them, most of these centers, they do not do an endoscopy for these patients, because they screen them through a questionnaire. The physicians actually go through them with their history and so on, and they find that there is no indication to do an endoscopy unless they are symptomatic or they have some form of GI symptoms, gastritis, GERD symptoms, and so on, that needs to be treated or needs to be evaluated, then they do it. So again, I think in our setting, we have to decide based on our experience and what is our preference.
Clinical judgment.
Yeah, clinical judgment, that's correct. Because I think by just saying that, you don't need to do a scope and anyone can swallow it, I think that is not right as well. We have to be, we have to side with clinical judgment, be prudent and make the choice on a case-to-case basis.
How about you? Do you scope? And Dato?
I'm a bit conservative about this because I'm looking at the legal aspect of things. I mean, it sounds really nice that you don't need a procedure to put in a balloon. Now, you can do 1,000 balloons successfully. All you need is just one that has a coexisting gastric problem. And that's going to ruin you because the next thing you know, the questions will be asked will be, why didn't you do an endoscopy? That's my concern. Otherwise, I think the concept is great. The ellipse sounds like a very good idea. Just a bit conservative about the legal aspect of this balloon.
Okay, we've got two participants who raised their hand. Dr. Sekapan and Dr. Umu, you'd like to unmute them and probably they can ask directly. Or Dr. Umu, you guys there?
Which, would you like to read out the question?
It's not. They just raised their hand. There are no questions here.
I see.
Yeah, or probably you want to type it out in chat box. I can read it out loud. While waiting for that, probably Dato, your talk is really an eye opener, you know. Probably when you guys, Mr. Vimal and all started it off, we were looking for patients, you know. Now patients are coming to us, you know. Now it's the other way around, you know. Now we have to live up to what we
You're famous, Mark. That's why.
So I think, like, you know, your talk is very important. We should head in that line, I think, you know, because now they're all coming, you know, it's like opening the floodgates. They all just start coming, and now when we can't offer, we can't live up to what we proclaimed earlier, it's going to, you know, backfire on us, I suppose.
For the government to say that they will cover for bariatric surgery, because if they say that, then the patients will feel that they're entitled to bariatric surgery treatment. And if you're not equipped, and you definitely will not be equipped, because there will not be enough funding for bariatric surgery, and they will start creating problems for you. That's one of the key reasons why MOH were very unlikely to say bariatric surgery is being offered in government hospitals.
I think, Mustafa, I want to ask you this. Mustafa, the pricing for bariatric has how do you, you know, you have so much experience in this, how do you market it? You know, we also can find a way to push it to the government to make it attractive to them.
Mustafa, you have to charge him for personal CME. You charge him, okay?
Okay, I think, okay, it's very simple.
You know what, Mustafa? Because me and Mr. May differ in this opinion. I think the pricing is, you know, something that when the patient pays, they feel that it's, you know, a bit mahal. But when you look at other surgeries in our profile, you know, like, you know, for other like bowel resection or for stomach and all that, it doesn't look as expensive as those. In fact, it is much more comparable. So, you know, it's two ways of looking at it, you know?
Okay, first of all, I mean, if we talk about this marketing, I mean, we first and foremost, we have to understand doctors, we are actually the worst people when it is come to management and doing things other than surgeries. Everybody agree on that? So if you want to put yourself in a different level or a different position, you have to outsource this. You cannot do it alone. And when you start to meet different type of people, and we are doctors who are sitting and doing surgeries. I'm talking about surgeon per se because most of the panelists are surgeons. We are people who are earning based case by case. But you have to understand somehow there are people that have a different mentality, different thinking. It's not about earning, but it is actually how to build up your name in a way that people, they can understand the value of your surgery. Okay, now this is actually, you will find it has a double action in you. Number one, people, they will have more awareness. And because of that awareness, basically, they will come to you very easy. They don't come to attack you and tell you about, oh, bariatric, I think this is just not a good surgery or whatever. No, they come to you that's already convinced. I want sleep, I want bypass, how many bypass, whatever they are in their mind. Or even talking about the balloons. But at the same time, is actually, you put yourself, you set yourself in a category. It's not to compare yourself to others. No, it's just that because when you get the flow of cases, then you know that you are all of a sudden, you have a good volume, good pool of patients, and that pool actually is just regenerate itself. And so it's need that amount of efforts that you put it at the beginning. And then after that, the thing is just go by a smooth flow. But again and again, you cannot just do it yourself. You need to outsource to somebody. But after all, you are the person. You are the main actor. You have the key factor. You should have the capability to talk in public and social people. And you know, social thing is actually something very dangerous because people, they can really attack you badly. So you have to be very careful as well. You do it right, everything will be all right. And I believe the price that we're able to achieve is quite comparable to other. I mean, till now there are some doctors in a different hospital, they charge per BMI. BMI 40 to 50, 50 to 60, different. I think Dato here also, he knew some of them. But this is not the principle. You just need to make it like a standard for everybody, make it affordable. We need to tone down in certain level to get the volume. If you combine things, now it's just that we are not matching ourselves uniquely. Everyone is doing something good, but in one part, but we are not doing everything in all the parts. If we all combine together, I think that will be the best marketing tool.
Well, guys, don't forget that if cost is an issue for patients, always remember that the public sector is always available. Bariatric surgery is available in Ipoh, it's available in Penang, it's available in KL, and I think you all know in UKM as well. So there is always another option where patients can go to. So I think Penang has as well, right? Penang GH, if I'm not mistaken.
Yeah, I think
it's offering as well, right?
Can we conclude, or shall we take more questions? Or 7:15 now?
Yeah, time.
Mr. Vimal? No.
You're breaking up.
Mustafa, you need to invoice
Can't hear you, boss.
I say, Mustafa, you need to invoice Ghaffur.
I will do.
Private tuition.
Hello.
Have a mutual understanding.
Hello.
Hello, yes?
Yes, I am Dr. Teo, a GP from Penang.
Yes, Dr. Teo.
Yeah, I would like to ask these questions. Mr. Kiru is my mentor in Penang. Yeah, I just want to ask whether post-bariatric surgery, is it common they need Saxenda to maintain their weight, to prevent weight regain? From your experiences, how was it? Do they need combination therapy post-surgery? Thank you.
I think that question to Dato G.
For me, why? I thought you were asking Kiru. I'm sorry. No, Dr. Teo, I think bariatric surgery is definitely a very effective method of weight loss. And in fact, it's the most effective weight loss treatment anyone can have in the long term. Now, if there is weight regain, or what we call weight recidivism, we must first investigate what the cause of the weight recidivism is in the first place. Is it because of dietary? Is it because they've some additional sugary beverages? They have introduced too much calories into their diet? Is it because there is a dilatation or distension in their pouch? So I think we need to investigate what is the root cause of their weight regain, and how many years has it been since their surgery before we actually think about starting Saxenda. Because if there is a pouch dilatation, for example, and if it's significant enough, then a revisional surgery will probably be more advisable rather than Saxenda. If it's a dietary issue, then you have to explain to the patient that Saxenda will just reduce the appetite, and it's just going to be a short-term thing. And if you do not change your lifestyle or your dietary habits for the long term, it's not going to work. You're gonna keep regaining weight all the time. I hope that answers your question, Dr. Teo.
I think we have to conclude. We've already shot past 7:15 now. I think I want to take the opportunity to thank everyone, and maybe Mr. Vimal can say a few parting words before we end.
Can't hear.
I think we can't hear you.
Something right with your line, boss. We can't hear you.
Okay, Namaina. I think thank you everyone. I'll take the opportunity to thank all the panel members, and thank you everyone for tuning in. Please stay in for our next webinar in 2 weeks' time, which will be about upper GI. and we will have another round of eminent speakers to talk about this topic. And please don't forget to stay tuned for the QR code for the CPD points, and also for the membership QR code as well. And we hope to see all of you all in 2 weeks' time. Thank you again, and thank you everyone. Have a nice weekend and stay safe.
Well done,
Thank
you.
Good job, guys. Thank you.
Good night. Bye-bye.